Good morning, everybody, and thank you for coming to this morning's session. My name is Diana Ionescu. I'm a consultant pathologist and AP lead at BC Cancer in Vancouver, Canada, and clinical professor of pathology at University of British Columbia in Vancouver. In recent years, our concept of lung cancer have undergone revolution. And this is a statement made by Dr. Sanya Dasik, who's the current pulmonary pathology president. And myself and my co-speaker were thinking about talking to you today about the molecular biomarker revolution in metastatic non-small cell lung cancer. Given that oncology, it's a multidisciplinary discipline, and it's very important for pathologists to play an active role in this multidisciplinary care, I invited as a co-speaker today Dr. Doru Paul, who's a medical oncologist and associate professor of clinical medicine at Weill Cornell Medical College in New York City, to give us the oncologist perspective of molecular biomarkers in metastatic non-small cell lung cancer, while I'll try to give you the pathologist perspective. We will try to organize our talk, which is very comprehensive based on the title, through an introduction, then talking about standard of care biomarkers, new biomarkers, and emerging biomarkers. And to make things more interesting, we also are going to do this through two case presentations. You are familiar with the learning objectives from the website. As you can see, they are quite comprehensive, and each of them can actually represent the topic for 1 hour, or if you are really into lung cancer, into a couple of hour lecture each. So we will try to really give you some practical points related to each of these learning objectives, and hopefully this will be something that you can apply to your daily practice. So why are we talking about biomarkers? Why is biomarker testing essential? In my mind, a biomarker is the first essential step in metastatic non-small cell lung cancer diagnosis, stratification, treatment, and also in ongoing monitoring of patient response. The pathologist must have a true understanding of testing considerations for current and emerging biomarkers, and we need to know what type of sample will yield the most actionable information, which testing methodology is the most appropriate, and which biomarkers to assay, and it's the case for each of our patients. So without further ado, I'm going to move on and talk about the standard of care biomarkers in metastatic non-small cell lung cancer. This pie chart, I think you've seen probably multiple pie charts such as this one, looking at the targetable driver mutations in non-small cell lung cancer. The numbers vary. They do vary based on the population that we look at, Caucasians versus Asians. It also varies depending on when this pie chart was made. However, I think it's important to know that approximately 50% of the patients with advanced non-squamous non-small cell lung cancer do have a targetable driver mutation. Some of them are more prevalent, such as KRAS and EGFR, but many of them have a very low prevalence, around 2%. The latest NCCN guidelines, the version that we just accessed a couple of days ago, lists a number of biomarkers in metastatic non-small cell lung cancer that they recommend to test in clinical practice. And as you can see here, it includes some of the most common EGFR mutations, KRAS mutations, ALK rearrangement, ROS, BRAF, NTRK, MET exon 14 skipping, RET, and also PD-L1 testing. We will be talking about some of them in more depth during the presentation. So let's move on and talk about our first patient. This is a 65-year-old woman, a non-smoker, who presents to the emergency room with abdominal pain and was diagnosed with acute diverticulitis by CT scan. At the time of the diagnosis, the chest CT showed an incidental finding of a lung mass. There was a 5 by 3.6 by 3.6 centimeter spiculated mass located in the left upper lobe with pleural and diaphragmatic nodularity, small pleural effusion, and confluent adenopathy that extended into the left hilum and mediastinum. But PET scan, the lesion was PET avid, and also a metastasis was identified on the third sacral segment suspicious for bone metastasis by radiology. A bronchoscopy was performed, and we received in pathology 3 specimens, left upper lobe bronchial washings, brushings, and biopsy, and they were all positive for adenocarcinoma, as you can see on the left-hand side, and it was strongly and diffusely TTF1 positive, consistent with a lung primary. Biomarkers that were performed on the transbronchial biopsy were by immunohistochemistry, ALK and ROS were negative, and PD-L1 performed using the 22C3 PharmaDX kit showed the tumor proportion score between 1 and 49%. An NGS panel was also performed. At the time of molecular testing for this patient, at the cancer agency, we used a DNA hybrid capture gene panel, and we're going to talk about these technologies a little bit later in the presentation. So the molecular pathology report for this patient was reported, as you can see here, using the tier reporting system, looking at variants of clinical or functional significance, and then variants of unknown significance. Later on, we actually moved on and reported them using all 4 tier variants. So for this particular patient, what was identified was a mutation in the EGFR gene. As you can see, using this nomenclature, it's a little bit difficult, even for a medical oncologist, I think, to understand exactly what it is. And this brings up an important point for pathologists. It's very important that while our molecular pathology reports are comprehensive, they also need to be easy to understand for our clinical colleagues. So another way to actually state that particular mutation, it's an exon, EGFR exon 20 insertion, and stating exactly the insertion points, because I'm going to show you that that's important for treatment. So exon 20 insertions represent approximately 10% of all oncogenic EGFR mutations. They are the 3rd most common class of mutations after the canonical EGFR mutations, deletion 19 in exon 19 and L85AR in exon 21. These are heterogeneous class of mutations, and as you can see on this diagram, some of them are sensitive to the 1st to 3rd generation of TKI inhibitors, but some of them actually are confer resistance to these therapies. And that's something that's very important for medical oncologists to understand from the pathology report. Just as a one-slide overview of EGFR mutation, although this is an older slide, it's actually from 2010, it still is my most favorite slide to present for EGFR. If you look on the lower part of this slide, you can see the mutations associated with drug sensitivity, and you can appreciate that on exon 19 and exon 21 are the common mutation in EGFR, which account for approximately 90% of all EGFR mutations. We have also activating mutations in exon 20, including the exon 20 insertions that we're talking about today, and some in exon 18. On the upper side of the slide, you can see the mutation associated with drug resistance. And the most important one is the T790M, which actually accounts for 50% of the resistance mutations to TKI inhibitors. So how do we test for EGFR mutations? There are 2 main ways to identify these mutations, either by PCR or by NGS. PCR is typically performed sequentially in order to identify only the most common genetic alterations, and it's limited in its ability to detect molecularly heterogeneous mutations, such as exon 20 insertion mutations. They do require a relatively large tumor tissue sample, and therefore, as you can see with this arrow, they really decreased in usage in the last decade. On the other hand, NGS simultaneously tests thousands of genes without prior sequence knowledge, and is a valuable tool to identify molecularly heterogeneous sequence alterations, and use only a single, usually a smaller tissue sample, and that's why it's increasing popularity. The take-home message related to testing for exon 20 insertion is that PCR identifies only half of EGFR 20 exon insertions variants that are identified by NGS, and therefore NGS is the desirable method to test for these mutations. Now that we have a molecular pathology report and we transfer the patients to the medical oncologist, we're going to see what Dr. Paul is going to do with the results on this patient.
Thank you. So these exon 20 insertions are an unmet need in the treatment of EGFR mutated lung cancer, because as you can see, the survival with the exon 20 insertion mutations is really inferior if you're looking at the EGFR mutation. So you have at 5 years an 8% survival. So compared with other EGFR mutations, the exon 20 insertions are associated with 75% increase in the risk of death, 93% increase the risk of progression, and 60% shorter time to next therapy. So our patient had an exon 20 insertion that is not sensitive to one of the EGFR sensitizing mutations, and therefore the response to even a third generation TKI like osimertinib would be really unsure. And currently there is no first line that would target this particular insertion that our patient had, which is a resistant mutation. So subsequently the patient was treated with 6 cycles of carboplatin and pemetrexed. And at that time, after the treatment, there was a response after the first 2 cycles, and the treatment was continued up to 6 cycles and was switched to maintenance pemetrexed. Unfortunately, on maintenance pemetrexed, the patient progressed and then was switched to a new oral drug, monocertinib, and I'll talk briefly about monocertinib, that was based on her exon 20 insertion mutation, the specific mutation. A good response was noted for approximately 17 months. Then again, disease progressed with a new level metastasis. Also, she received SBRT, so focal radiation to a lesion in the brain, while she was on monocertinib. She again progressed, and she was switched to amivantamab, that is a new antibody that is targeting this particular exon 20 insertions. And now, after 6 months, there is again progression in the lung. The patient received palliative radiation to the chest and to the sacrum where there is a bone lesion. So here are, from the beginning, the different CT scans that are showing you initially when the tumor was approximately 5 centimeters. Then, after being treated with monocertinib, and you see that the tumor was reduced. And this is the last CT scan here that, again, you have recurrent disease. And you can also see here there is this pleural effusion that had to be tapped. So, monocertinib in EGFR exon 20. These were the 2 studies that were done, and the drug was approved based on these 2 studies. You see in the first one that the response rate in this waterfall slides that was approximately 43%, and then in the second study that was performed was 22%. So at this point, monocertinib is approved, has been approved since 2021 for this indication of the exon 20 insertions. What is important to note is that the drug is not very easy to tolerate because in approximately 70% of the cases it's associated with diarrhea. And also, at this point, there are several studies that are ongoing to see whether this treatment can be also started de novo as a first intent in these patients that have the exon 20 insertions. So you see the response is between 20 and 40%. The response to carboplatin or cisplatin with pemetrexed, it's in the range also of 40%. So a randomized study is clearly needed before saying that we can use this type of oral agent in the first line of exon 20 insertions, metastatic adenocarcinoma of the lung. This is the other drug that was used. It's amivantamab. So amivantamab is a bispecific antibody, both EGFR and MET, and it's a fully human antibody. So this is similar to cetuximab in the sense that it's inhibiting the EGFR. And as cetuximab, it has this characteristic rash, like an acne, that appears in approximately 85% of patients. It's also associated with diarrhea. In terms of responses, the responses are in the 40%, so the response rate is in the 40%. And it has been also approved in 2021 for the treatment of specifically exon 20 EGFR insertions. So you can see here that for this type of cancers where you have the exon 20 insertions or the MET amplification because it's a bispecific antibody, certainly amivantamab, it's a drug that can be used. Same thing, it's in second line. It has to be compared with frontline chemotherapy before becoming also of use in the first line. So what did we learn so far? First of all, the exon 20 insertions are the third most common EGFR mutations, and they are heterogeneous. Some of them, they are more sensitive than others to therapeutic manipulations. There are several methods to test for these EGFR mutations. So first of all, you can look specifically for a mutation, like, for example, in the T79TM, you can even do ctDNA from the blood. Then you can do testing as a part of gene panel, or you can do hotspot testing looking at zones of the EGFR gene. And all this can be done by either PCR, either NGS. As Dr. Naus was mentioning, NGS is detecting almost double the number of insertions when you have an EGFR 20 exon insertion. The turnaround times are highly dependent on technology. In our institution at Cornell, it takes approximately 12 to 15 working days to have the results. And of course, there are several companies that you may be familiar with that are doing either circulating tumor DNA, either whole exome analysis that have a turning time also in the range of 2 weeks. Pathologists are critical, really, in coordinating tissue acquisition, processing and selecting the best tests, and communicating with pathology should be really standard of care in tumor boards, and pathology can really inform the medical oncologist what would be the best test to perform according to the question that is asked. Now I will start talking about the second part of the talk, new biomarkers in the metastatic non-small cell lung cancer. The second case is a 75-year-old Caucasian woman, non-smoker, that was referred by a family doctor to a pulmonologist because she had a persistent cough for several months that's been progressively worse, with copious foamy whitey secretion suggestive of bronchorrhea. On the CT scan, she had a left lower lobe predominant pneumonia with minimal involvement of the lingula and the right lower lobe. At that time, the pulmonologist chose to do just routine CT scans. And on the routine CT scans, she had worsening this left lower lobe and right lower lobe infiltrates. There was no lymphadenopathy at the time. But because of this progression of the infiltrate, a biopsy was performed. So this is how the CT scans were looking prior to surgery. You can see here the lesion. And you can see here the progression, in fact, of the infiltrate over time. So in 6 months, the infiltrate worsened. At that time, I will let Dr. Naus explain you further.
So as usual in the lung, when a procedure is performed, we don't only receive a biopsy. It is rarely the case that a single specimen is received from a procedure done in the lung. Usually there are bronchoalveolar lavages, washings, brushings, biopsies, sampling on the lymph nodes all at once. This patient didn't have lymphadenopathy, so there was no sampling on the lymph node. But there was a biopsy in the bronchoalveolar lavage received in the laboratory, and you can see here it was scant, so not too many clusters, but they were highly diagnostic. So it was diagnostic for adenocarcinoma, which was again TTF1 positive, consistent with lung primary, and between the biopsy and the cell block from the bronchoalveolar lavage, the cell block seemed to be better. As I said, the cellularity was low, but the tumor content was very high. So it was a cell block that was almost entirely consistent of tumor, and that was the best specimen for testing. So several biomarkers, again, were performed by immunohistochemistry. ALK and ROS1 were negative. On this patient, because less than 100 tumor cells were present, PD-L1 testing, the sample was inadequate for PD-L1 testing. And again, we perform NGS, this time with a new panel. This panel is that we're using currently at the Cancer Agency. It's an Illumina focus panel. And what's important about it is that it does include DNA-based testing for fusions. And that's going to be important for this patient because on the pathology report, you can appreciate that a gene fusion was detected. And this is the fusion between the RET gene, and the fusion partner is this CCDC6, which is one of the most common partners that are fused with RET in non-small cell lung cancer. Another thing that I would like you to appreciate here is that there are 4 tier variants reported currently in the pathology report. So with this information in the pathology report, I would like to just tell you that there are different methods for identifying fusions. And we're not talking about RET fusion. I took this as an example, but any fusion, NTRK, RET, NRG1, ROS, ALK, can be identified using similar technologies. We can use IG immunohistochemistry for some of them. We can use FISH, RT-PCR, multiplex panel, or whole genome sequencing. Turnaround time and cost definitely goes up the more complex these technologies are. And important to know is that immunohistochemistry can be used for screening, but it's not the definitive test for some of the fusions like ROS1 and NTRK. And also, important for FISH is that it could be the method of choice, maybe not for non-small cell lung cancer, which is a cancer with a high incidence and low prevalence of fusions, but for cancers that have a low incidence and high prevalence of these fusions. So for such cases, FISH may be the method of choice. So if we look at approaches for fusion detection by NGS only, there can be classified in amplicon-based, anchor multiplex PCR, and DNA hybrid capture. The DNA hybrid capture are the most popular. I give you here some examples. They are not all inclusive. But for example, Foundation Medicine, the MSK Impact panel, and our little Illumina Focus panel, just with 50 gene, it's a DNA hybrid capture one. The reason this is such a popular testing technology is because it really gives very high quality results and can detect novel fusion partners. However, this may not be also the most economical one. The amplicon-based is also very popular, especially if it's performed on the DNA. It can be performed on the RNA as well, but RNA is much more difficult to obtain from FFPE. It does require low quality and quality of DNA, and it works very well on small or compromised samples. I think it's very important for pathologists to know the advantages and disadvantages and the limitations of these technologies, especially when you look on bringing something new to your laboratory. So let's go back to our patient. Her bronchorrhea really got worse, and they decided to do a palliative surgery in order to help her with her symptomatology. So a left lower lobe lobectomy and left upper lobe wedge resection was performed, and it showed an adenocarcinoma, and there were actually multiple foci. And I think that correlates very beautifully with those patchy infiltrates that Dr. Paul showed on the CT scan. It was 50% papillary, but it had a few other morphologies as well. The largest focus was 11.5 centimeter. I think this is very interesting because there wasn't really an actual mass identified on CT scan. Everything was like a pneumonic infiltrate. Anyway, no pleural invasion, no lymphovascular invasion, but very characteristic for the type of adenocarcinoma with papillary histology, they were spread through air spaces present. And here are the pictures. So the papillary type adenocarcinoma and the spread through the air spaces. You can appreciate the alveolar wall that are maintained, and the clusters of tumor are in between these normally looking alveolar walls. By immunohistochemistry, again, the tumor was consistent with lung primary being strongly and diffusely positive for TTF1 and NAPSIN-A. And now we're going back to Dr. Paul to see what happens with the patients further.
So, this patient had a CT scan of the abdomen, pelvis, head and neck, brain scanning also, bone scan, and there were no distal disease. So at this point, the disease is really localized only in the lung, and as Dr. Naus described, there are lesions that are present in both lungs, so it can be considered metastatic disease. Also, on a PET scan that you can see here, the SUV was really borderline, and so basically the tumor was not uptaking glucose, and as you know, in lung cancer, the tumors may use also glutamine and other fuels. At that time, the patient was referred to medical oncology. So the somatic RET fusions and mutations, they're really associated with the oncogenesis in multiple locations. You may be familiar with the medullary thyroid cancer, where they are present both in inherited syndromes, like MEN1 and MEN2, or in de novo mutations. In lung cancer, we are talking really about fusions, not about mutations. And in this particular patient, the fusion that was present is the CCDC6, which is the second most common fusion after KIF5B. It's approximately present in 25% of the patients with RET fusions in adenocarcinoma of the lung. The other one, the most common one, is present approximately 40 to 50%. So these two mutations are really the most common mutation present in patients with RET fusions in lung cancer. So RET is an interesting protein because it is present in embryogenesis, where it plays a role both in the development of the nervous system, the hematopoietic system, also the GI and the GU systems, both the gastrointestinal and the urologic systems. In cancer, it can have both mutations that are present here, like in the medullary thyroid carcinoma, or mutations inside in the tyrosine part that may be present both in medullary thyroid cancer or in thyroid cancer. In lung cancer, there are these fusions that are present between portions of the molecules, and it's a heterogeneous disease, and there are more than 30 different companions of RET that have been described, besides the two that I just mentioned. And if you look at the RET pathway, in fact, it has a pleiotropic role both in gene regulation, leading to division, leading to invasion and metastasis, because it's activating the PI3K pathway, the KRAS pathway, the MAP kinase pathways. So selpercatinib, it's a specific RET fusion positive non-small cell lung cancer inhibitor that was developed. The originally trials that were using other TKIs like cabozantinib, for example, were not leading to, on one hand, good responses. On the other hand, they were very toxic. So more specific inhibitors were looked, and selpercatinib was the first one that was approved in 2020. Based on the libretto studies, there were two libretto studies, and the overall response rate was 64% in second line after platinum-based chemotherapy, and 85% in the naive patients. There is another drug, pralsetinib, that has been approved this year, in 2021, for the same indication in patients that have RET fusions. The difference is really in terms of the side effects more. Selpercatinib has a little more hypertension associated, and pralsetinib has a little more diarrhea associated. But really, in terms of the side effects, they're very similar. In terms of the efficacy, The progression-free survival with selpercatinib in patients that were not previously treated was superior. So if you're thinking about using de novo, clearly selpercatinib should be used instead of pralsetinib. In terms of the second line, they are similar. So now I'm going to talk about something which is of a lot of interest to me, which are the emerging biomarkers. And this is the pie that has been presented here. And you have approximately 40% of these KRAS mutations in non-small cell. They are G12C. And now we have a drug that has been approved. So overall, in adenocarcinoma, approximately 13% of mutations, they are KRAS G12C, and they're amenable to treatment with sotorasib, which is the new inhibitor. This pie, it's, if you look at the year, was published initially in 2016, and now we are 6 years later. So what I'm going to show you is really making the things a little more complicated and looking at what's going on if there is an association between different mutations. So we're going to really to the next level in which you're not thinking also in terms of one mutation, but also association between mutations. And I'm going to present you this interesting study, Poseidon study, recently presented at last month at the World Lung. So the KRAS mutations in metastatic non-small cell lung cancer, they're heterogeneous and they're typically considered mutually exclusive. Although as part of my PhD 7 years ago, we found that 40% of this KRAS mutation, they can have a second driver present. We presented this in 2015. And then it was also presented by a German group at ASCO in 2015. And there's specific commutations that you can see here that are present in the KRAS G12C. For our interest, there is this STK11 present in approximately 30% of cases, and the Kelch-like ECH-associated protein 1 mutation, KEAP1, present in 13 to 27%. STK, KEAP1, and KRAS, they are really a bad company, and when you have all three of them present, the responses to the sotorasib are like 10%. STK is the third most commonly mutated gene in lung adenocarcinoma after TP53 and KRAS, and it's a tumor suppressor, so like TP53. The role of KEAP1 is in oxidation, and in order for tumors to survive in the circulation, they need to have strong antioxidant metabolism, and KEAP1 plays a role in that. This is the study, the Poseidon study. It randomized more than 1,000 patients. They were all EGFR and ALK wild type. They all had a good performance status. PS performance status was 0 or 1. They were all treatment naive for metastatic disease. And they all had a tumor biopsy and also a baseline plasma sample for circulating tumor DNA. There was a further stratification done based on the PD-L1 expression, the histology, non-squamous versus squamous, and the disease stage 4A versus 4B. So the three arms, the first arm was looking at durvalumab, which is a PD-L1 inhibitor, plus tremelimumab, which is a CTLA-4 inhibitor, plus chemotherapy that was given with carbotaxol and pemetrexate for 4 cycles. The second arm was just using durvalumab and chemotherapy, and the third arm was really the classical chemotherapy with pemetrexate and platinum salts. Subsequently, the patients were allowed to receive further durvalumab until progression disease, or the combination of tremelimumab and durvalumab. So what is interesting here is that if you're looking at the survival curves in the KRAS mutated patients, you can see that the triplet had really the best probability of overall survival. In terms of the triplet for the wild type, there was no difference. Secondly, for patients that have a mutation in their STK11, again, the triplet performed very good, and there was a trend towards overall survival improvement. And third, also for the KEAP1 mutation, there was a trend towards overall survival improvement. So in this experimental analysis from Poseidon, there was a trend for benefit in using tremelimumab, durvalumab, and chemotherapy for STK11 mutations, for KEAP1 mutations, and for the KRAS mutation in metastatic non-small cell of the lung. So sotorasib was already approved in 2021 for this mutation G12C, which again is present in approximately 30% of patients. So if you're looking in this study published in New England Journal of Medicine, what is interesting here is if it's the response rate in terms of different mutations was best if the KEAP1 was wild type. So you see here, STK either mutated or wild type has the best response really when the KEAP1 is wild type. So if you're going back to the Poseidon, what is becoming interesting in terms of biomarkers is that if you have a patient that you're really considering giving sotorasib, if the patient has a triple mutation, all three STK11, KEAP1, and KRAS mutated, the response rate is like 10%. And I showed you already the response rate in the ranges of 40% if you're using the triplet of a CTLA-4 inhibitor, a PD-L1 inhibitor, and chemotherapy. So you can really stratify your use of sotorasib, and patients that have a wild-type KEAP1, they can have the oral drug sotorasib, which of course is not lacking side effects. Again, it can have some diarrhea. Also, we have to look at EKGs for rare QT prolongations, but it's better tolerated than the chemotherapy, immunotherapy combo. Now I'm going to talk to you about immunotherapy, which has been really a very hot subject in the last 10 years, in the last decade. So you have this classical PD-1 expression, the mutational load, and the CD8 T cell density. So just to remind you, these are, in terms of prognostic, the PD-1 expression and the mutational load, they cannot really tell you if the patient survival is going to be improved. The TILs, the tumor-infiltrated lymphocytes, in fact, they do, so they have a prognostic advantage. In terms of the prediction of response, all three of them, the PD-L1 mutational load and the CD8 T cell, they have a role. So the PD-L1 expression, you can see here that combined with the TILs is present in approximately 45% of cancers. It is not staying the same because it can change with treatment. As you can see this in this case, after crizotinib, the PD-L1 expression was 50% before it became negative. So it's a dynamical marker. The tumor mutation burden has been demonstrated, in fact, to have also a role, and you can see here stratification between different tumor mutation burdens, and the lung cancer is clearly has been proven in more than 14 randomized studies to play a role. And you can see here actually the different oncogenes, they have a stronger or less association with the tumor mutation burden. The KRAS and the BRAF has a strong association with the TMB. So the immune infiltrate is something which is very interesting, and you can see here that in different type of cancers, you can have different immune infiltrates. And one of the most interesting paper that was published lately, this is published 4 years ago, is looking really at the immune landscape of cancer, and we are combining different information taken for the RNA-seq, the mRNA, the DNA copy number, mutations, clinical data methylation, and then we can have 6 immune subtypes that are very important because they are associated actually with the survival. The inflammatory type, in terms of immune type, is the one that has the best prognostic. If you're looking at the immune infiltrate in terms of percentage, you can see that lung cancers, both the adenocarcinoma and the squamous cell, has the highest infiltration. And then if you're looking at different types, you see different types of lung cancer, squamous versus adenocarcinoma, they have different percentage of these immunotypes. And you can see that maybe the fact that the adenocarcinoma metastatic has a better prognostic is that it has more of this C3 type of immune infiltrate. You can see here that the C3 type is associated with the best prognostic. So it's becoming here more and more clear that you have all these elements. You have on one hand the genes that are mutated, and you have also immune infiltrate, and you have the communication between cells via soluble proteins. So they are not independent. So when you have certain mutations like KRAS, for example, it's inducing an exclusion of the B cell and the T cell in the environment. So this is why the near future is going really to be in combination treatments that are combining TKIs with immunotherapy. And as you have seen in breast cancer being used, the oncotype for women in terms of receiving adjuvant treatment, women that are EGFR, that are ERPR positive, HER2 negative, probably the same thing is going to happen in the near future in which you have these scores that are going to be developed with different level of information, both coming from the type of mutations, from the immune infiltrates, from the type of immune cells, and they're going to have really very important roles, both the prognosis and the prediction of response to treatment. So in the near future, these 4 types that I described prior, with immune environment that it's rich in cells, you have both PD-1 expression and TILs, immune environment that is a desert, so-called immunologic desert, immune environment which you have at the periphery, the CD8 cells, and the immune environment where the CD8 cells are inhibited by the tumor. So we can think of ways, and you're going to have this slide and you can analyze it after the talk. You can have different ways of doing studies and targeting specifically different of these environments. So the conclusion is that this is an extremely exciting field, and at ASCO this year you have all these talks about machine learning, which are integrating data from different levels, from the intracellular, extracellular, and also clinical data. And I think this is really the future in oncology, and for you pathologists, I think a lot of interesting things are coming. I will tell you briefly, in terms of this different immune infiltrates, what is important to remember that in metastatic lung cancer, there is approximately 40% of the PD-L1 expression more than 50%. So you have more than 50% PD-L1 in approximately 40% of cancers. And then in terms of the tumor mutation burden, approximately 40% is more than 10 megabases. And the third thing in terms of that infiltrate with the juice infiltrates, it's again approximately 40%. So knowing these 3 numbers, which are between 40 and 50%, you can understand that with our best tools now, combining immunotherapies like CTLA-4 inhibitors or PD-L1, we can achieve in the range of like 50%. So this is the magic number. This is at this time where the limit is. Thank you very much.